one of the other reasons why food allergy might be increasing is when we choose to introduce foods into the diet of children. And we'll go a little bit more into this, but there is a distinction between cutaneous or skin exposure to antigens versus by mouth. And skin exposures might actually be sensitizing or pro-allergic, whereas exposures by mouth might be pro-tolerance. Okay, so Mark was just asking how many fatalities there are from food allergy each year, and what we've identified from these fatality registries is that there are certain risk factors that are predictive of fatal or near-fatal food-induced anaphylaxis. One of them, which is probably the most important, is a delay in administration of epinephrine. And so most of the cases of fatality actually involve epinephrine having been delayed. Allergy to certain foods, so peanut, tree nuts, fish, or shellfish. Adolescence or young adulthood. So this is a time of risk-taking, both in terms of not having the epinephrine autoinjector on hand immediately, and also not necessarily adhering to the food allergy diet. And then asthma is also a risk factor for fatal anaphylaxis. The absence of skin symptoms is also another interesting predictor of fatal or near-fatal reactions. Most of us think that if someone is having a food allergic reaction, they're bound to have cutaneous findings like flushing or hives or swelling. But in fact, 20% of reactions involve no skin findings at all. And when you look at fatal reactions, 80% of them have no skin findings at all, which probably leads to a delay in terms of treatment. So going back to our case, there were several features of this case that were important to note because they highlight predictors of severe reactions. One, this was an adolescent. Two, he had peanut allergy. Three, he had asthma. His symptoms did not involve any skin symptoms at all. And luckily, he did administer epinephrine quickly, but that, if he had not, that would have been a risk factor for a severe outcome. So now we're going to focus on peanut allergy. And you might wonder why, in the media, in research indeed, why we focus so much on peanut allergy as opposed to other food allergens. As I alluded to before, this is actually the most common food allergy in the United States. It affects 1% to 2% of people in the U.S., and this prevalence has tripled, more than tripled, in the past couple of decades. And so each year, there are over 100,000 now new cases of peanut allergy annually, which is an astounding figure. In addition, peanut is the leading cause of fatal and near-fatal food-induced anaphylaxis. While any food allergen, in theory, could cause a fatal reaction, peanut is the one that is the most likely to do so. And then third, peanut allergy is usually lifelong. And so unlike other food allergies, such as cow's milk or egg or soy, which have a very high rate of being outgrown, peanut allergy, in most cases, is lifelong and persistent, and less than 20% actually experience resolution. So what are some of the risk factors for developing a peanut allergy in the first place? Well, one of the most important is a personal history of atopy in the child himself or herself. So if that child has severe atopic dermatitis or egg allergy, those might be predictors of developing a peanut allergy. Family history is also important. And so if there's a family history of atopy in a first-degree relative or of peanut allergy itself, that does increase risk. And so, for example, if a child has peanut allergy, their sibling has about a 7 or 8% risk of going on to develop a peanut allergy, which is higher than the 1% to 2% population-based risk. Genetic factors also seem to be at play, and so there are certain loss-of-function mutations, for example, in filaggrin, which is important in the integrity of the skin barrier, that seem to be predictive of a risk of peanut allergy. And then finally, delayed oral exposure to peanut. So the age at which peanut is introduced, as we'll go into, seems to be one of the important risk factors for whether peanut allergy develops. So the title of the talk is Cracking the Nut. And when you think about this peanut allergy problem, it's obviously very prevalent, obviously very severe, and these kind of highlight the reason why this is one of the food allergies that we want to really target first. And the question is, well, how could you crack the nut? How could you solve this problem? One of the areas that one could target is these new cases annually. And so if we could determine interventions that are very effective at preventing, primary prevention of peanut allergy, that would really put a huge dent into this problem. In addition, it's the leading cause of fatal and near-fatal reactions. And so if we can develop immunomodulatory treatments that even if they don't completely get rid of the peanut allergy, if they just decrease the risk of these severe reactions, that might be another way of cracking this nut, so to speak. And then third, this is often lifelong, and so ideally, if therapies could be developed that are actually curative so that the patient doesn't have peanut allergy anymore and can freely eat peanuts or choose not to, then that would be a third way to target it. But we'll start first with this notion of prevention, which I'm sure many of you have heard about in the past couple of years. And I put this slide up because this is one of the areas within food allergy where there's been a complete reversal of our understanding of appropriate recommendations. And so medical knowledge, as we all know, is constantly evolving and has a very short half-life of probably only about 5 to 7 years. And because of this, we might sometimes make incorrect recommendations based on the current set of evidence that we have to evaluate. And it does appear that when our academic organizations were making recommendations in the past with regard to when to introduce these allergenic foods, the recommendation to delay introduction was not correct. And back in the year 2000, for example, there was a recommendation because of a possible decreased risk of food allergy to hold off on cow's milk until after age 1, and egg until after age 2, peanut, tree nuts, fish until after age 3. We now know that that was wrong. But fast forward about 8 years to 2008, then they changed the recommendation but really didn't make one. And so there was no evidence at that time that delaying introduction of these highly allergenic foods was protective, but no specific guidelines otherwise were proposed until 2014. And that's when there was an accumulating wealth of observational data that perhaps delaying introduction of complementary foods might actually increase the risk of food allergy. And in fact, early introduction of these foods might decrease the risk not only of food allergy, but other comorbid atopic conditions such as asthma and eczema. But all of the data up to that point was observational and subject to confounding bias. And so it wasn't until 2015 when a landmark trial called the EPIT trial was published. And this is the first randomized clinical trial of early peanut introduction during infancy and the risk of going on to develop peanut allergy later in childhood. The results of this trial were so striking that it resulted in initially a consensus guideline statement, and then last in 2016, an update of the guidelines from the NIAID of what we should be doing in terms of food allergen introduction. So to go into a little bit more detail about the LEAP trial, why did they think that this might be a good idea? Well, the observational findings were striking, and Gideon Lack and George Dutoit in the UK had done prior studies that showed that the risk of peanut allergy was 10 times higher in Jewish children in the UK versus Jewish children in Israel. And in this set of studies, they adjusted for lots of other potential confounding variables such as ATP, genetics, socioeconomic status, peanut allergenicity, and the only significant difference that remained was when peanut was introduced. Because in Israel, peanut was introduced very early in childhood, whereas in the UK, due to these guidelines that we discussed, there was a recommendation to delay introduction until later in childhood. And so this formed the rationale for going to do this clinical trial, which really sought to determine whether early introduction of peanut to high-risk infants is indeed protective against later development of peanut allergy. So the population, this was a large clinical trial of over 600 infants who were at risk for food allergy between the ages of 4 to 11 months. And they were defined as being at risk because they either had severe atopic dermatitis and or IgE-mediated egg allergy. And we'll go into a little bit more detail about how they defined each of those. They were then randomized into 2 groups. And so the intervention group consumed peanut consistently until age 5 years. The avoidance group strictly avoided it until age 5 years. What's interesting is that this cohort included a majority of children who had negative skin testing to peanuts, but some of them, 98, actually did have small positive skin tests to peanuts. And so skin tests are what we do in the allergy practice to determine whether a child has what's called sensitization to peanut, meaning that they make IgE against peanut in their skin. And some of these children in the LEAP trial actually still had small positive skin tests that were about 4 millimeters or less. So in terms of how they define high risk, and this is subsequently what's been used in a lot of the guidelines, with regard to egg allergy, it was having a skin test to egg that was 6 millimeters or greater, or 3 millimeters or greater if they've had a prior allergic reaction to egg. And then eczema that was severe. And so this was defined as either having a SCORAD evaluation greater than or equal to 40, or eczema that's so severe that it requires application of topical steroids or calcineurin inhibitors at least 12 of 30 days on 2 occasions in the past 6 months. And so what did they consume? And so this is interesting because obviously whole peanut is not recommended less than 4 years of age because it's a choking hazard. And so they introduced various forms of peanut. So smooth peanut butter mixed with either milk or mashed pureed food, bamba, which is a corn puff snack that's coated with peanut powder, which is most often how peanut is introduced early in infancy in Israel, peanut soup, and then finally ground peanuts mixed into other foods such as yogurt. And so they consume this at a quantity of about 6 grams of peanut protein weekly that was usually divided into 3 servings of about 2 grams each. And then at age 5 years, the participants underwent a peanut oral food challenge, double-blind placebo-controlled food challenge, and skin testing and IgE testing. And the findings are shown here. And what you can see right away, this is the intention to treat analysis, is that there's a striking difference between the avoidance and the consumption group and the rate of peanut allergy at age 5. And this is divided based on whether they were skin test negative, skin test positive, and then the whole cohort together. But you can see for the skin test negative cohort, they had about a 13% chance of peanut allergy at age 5 if they avoided peanuts, and that was reduced to 1.9% if they regularly consumed peanuts. And so the relative risk reduction combined was over 80%. So striking findings. There was very good adherence to the consumption of peanut in this cohort, and sub-analyses by race did not show any differences. And safety-wise, it actually appeared to be very safe. So there were no deaths. There were similar safety outcomes, in fact, between the consumption and the avoidance groups. And the risk of the food challenge was actually low. What's important to note, though, is that it wasn't 100% effective. And so 6 of 320 children who were in the consumption group still did go on to develop peanut allergy. Of note, adherence among those 6 was actually not very good. And so if there had been 100% adherence, maybe it would have been even more effective. So the LEAP trial publication left us with several questions. And one of the prime questions was, what happens if those children then stop peanut consumption because they were regularly consuming it up until age 5, 3 times a week, 6 grams. What if they stopped? And then the community started asking, well, what about other allergens aside from peanuts? And so we'll talk about 2 follow-up trials that looked at those questions. The first was called LEAP On. So this was the same cohort as the LEAP study, but they were advised to then avoid peanut for 12 months. And so the intervention group that had been regularly giving peanut to their child until age 5 was then told from age 5 to 6, avoid peanut entirely. And then at age 6, they would undergo a food challenge to see whether they could still tolerate peanut or not. And what was found is, depicted here, is that after 12 months of avoidance, there actually was no significant increase in the prevalence of peanut allergy among the consumption group who then began avoidance. And so this is data on the top from the primary LEAP trial, and you can look at the data below from the follow-on study, and visually they look very similar. And so there was not a jump in the avoidance group who had previously been regularly consuming peanut. What about other allergens? Well, the EPIT trial was done to try to look at some of these other allergens, including egg, milk, sesame, fish, and wheat, in over 1,000 children. And unfortunately, the results were not as compelling in this trial, probably related to poor adherence, because there were 6 foods that parents were advised to introduce simultaneously, and most parents in the trial couldn't, over almost 60% couldn't. But what's interesting, when you look at the peanut group in this, whether they introduced peanut or not, and then whether they reacted to peanut or not, per protocol, there was a reduction in the rate of peanut allergy at the conclusion of the trial from over 2% to 0. And so this somewhat confirms the results of LEAP in a separate population, that if peanut is consistently introduced early in infancy, it seems to be protective against later development of peanut allergy. And so this led to the consensus guideline statement that was released in late 2015, early 2016, where healthcare providers were recommended to introduce peanut into the diet of high-risk infants between 4 to 11 months, but there really wasn't much guidance about how to do that. Did they need to see an allergist? Did they need testing? And then other infants were recommended to possibly see an allergist. And so if they had early onset atopic disease, such as severe eczema, maybe go see an allergist. But it wasn't until the 2017 addendum to the NIAID guidelines that very specific recommendations were given for 3 groups of infants. First, those that have no eczema, no food allergy, it's recommended just go ahead and introduce peanut at whatever age is appropriate in accordance with the family's preference and cultural practices. If the child has mild to moderate eczema, it's recommended to do so, peanut introduction around 6 months. And then the group that we end up seeing the most are those that have severe eczema, egg allergy, or both. And what's recommended here is to strongly consider an evaluation by allergy for either serum IgE measurements or skin prick testing, and if indicated, an oral food challenge based on those results. And this is recommended as early as 4 to 6 months. And so since these guidelines were released a few months ago, we've been regularly seeing infants in our clinic who meet these criteria for high risk, and we're evaluating them by doing the testing and then proceeding from there with food challenges as indicated. Now, how do you interpret the results of those food challenges? And so this is intended more so for any allergy colleagues in the audience, but when we do the testing, the guideline release from NIAID gives pathways for both the serum testing and the skin prick testing based on those results, whether it would be recommended for them to introduce peanut at home, to undergo a supervised peanut feeding in the office, or to undergo a graded oral food challenge at a food allergy facility like ours. And so in terms of prevention, this really has revolutionized what we're doing for infants. And within our practice, we've definitely prevented the development of peanut allergy in many infants, which is incredibly rewarding because those are infants, many of whom had already started showing signs of trying to develop peanut allergy through their skin prick test results or their serum testing, but through early introduction, we were able to prevent that. And so that's wonderful, but then there's an entire population of patients who are already dealing and diagnosed with peanut allergy, who primary prevention, we missed that boat, and we're not going to be able to help them in that regard. And so that's where I want to shift gears now to talk about some of the really exciting immunomodulatory treatments that are for patients that have persistent peanut allergy. And some of these treatments are specific to the food allergen, peanut, whereas others are more non-specific. And we're going to discuss 3 food allergen-specific therapies: oral immunotherapy, sublingual, and epicutaneous. And as the names imply, the route of administration of the immunotherapy differs in each of these: oral by mouth, sublingual under the tongue for 1 to 2 minutes, and epicutaneous in patches that are changed out every 24 hours on the skin. Non-specific therapy are not directed towards a particular food allergen, but are more intended to be generalized immunosuppressants for the allergic response, such as monoclonal anti-IgE or omalizumab. And I'll just mention it, but there's been some mouse data about traditional Chinese herbs that might be protective or effective, but not human data that's been encouraging. And so just in the past month or so, in the Journal of Allergy and Clinical Immunology in Practice, there was a very comprehensive review of where we are right now with immunotherapy and food allergy. And this figure is taken from that article, and it really gives you a sense of, for each of the different foods and for each of the different methods of immunotherapy, where we stand currently in terms of both efficacy and safety data in clinical trials. And so you can see for peanut, there's efficacy and safety data available for OIT, for EPIT, and for SLIT. And there's some data for probiotics plus OIT as well. There's a few on here that I won't go into because they're very early in stages of investigation. But there are some ways to modify the food antigen to make it less allergenic, but still tolerogenic. And then there are some murine studies into nanoparticle-based therapies that have not yet reached clinical trials. And so when we look at allergen immunotherapy, this is something that we've been doing for decades for environmental allergens subcutaneously. And the premise in food allergy immunotherapy is the same. And so we're relying on delivering gradually increasing doses of specific allergens to induce outcomes. And it's important to know what are the outcomes of interest in these trials. One is desensitization. So desensitization refers to a temporary state, where as long as the active therapy is continued, there is a reduction in the propensity to react. And this is usually only achieved after months of therapy, and it does require ongoing active therapy. Tolerance is the goal that we're aiming for ideally. And so tolerance would imply an ability to ingest the food allergen without symptoms despite having prolonged avoidance of the food or irregular ingestion of the food. And so a situation where the patient doesn't have to take their immunotherapy every day. They can get to a point of tolerance where they can stop it, and then they're protected after that. Bless you. Because there's little certainty about the exact period that food needs to be avoided before you develop tolerance, there's in studies a term called sustained unresponsiveness, which we use as a surrogate marker for permanent oral tolerance. And this means that after some defined period after which therapy was stopped, we do a food challenge to see whether, having been off of immunotherapy for 4 weeks or 6 weeks or 8 weeks, the patient is still protected. This usually requires years of therapy. So this gives you a schematic of a typical OIT dosing protocol that we use in these clinical trials. And so usually on the first day or two, we're rapidly escalating the dose, and then the participant is usually brought back the next day to repeat the dose, and that will be their starting point. Then they go home, and they take this immunotherapy daily, and then they usually every 2 weeks undergo dose escalation or updosing. This build-up phase of immunotherapy is usually weeks to months, but the goal is to get them to a maintenance phase, a maintenance dose, which then would be continued anywhere from months to years. At the conclusion of that maintenance dose, while they're still on active therapy, a double-blind placebo-controlled food challenge would be performed. And this would give you information about whether that patient is desensitized, whether they are able to tolerate a higher dose of that food allergen than they were beforehand while still on active therapy. Then most of the studies will have a period where then they stop therapy in either 2 weeks, 2 months, sometimes longer. They're brought back for another double-blind placebo-controlled food challenge, and the result of that challenge will tell you about sustained unresponsiveness or tolerance. And so the studies are built to try to assess for both of those potential clinical outcomes. Now to dive a little bit deeper about the mechanisms that might be at play immunologically with each of these forms of immunotherapy. So for all of them, there has to be an antigen-presenting cell that recognizes that antigen. For oral immunotherapy, it's dendritic cells in the gut. For SLIT, it's Langerhans cells in the oral mucosa. And for EPIT, it's Langerhans cells in the epidermis. Those then will go to draining lymph nodes, mesenteric, submandibular, regional, and promote the development of regulatory T cells. And those regulatory T cells are food-specific, and through production of IL-10, TGF-beta, they induce end cellular outcome changes. And so T cells actually shift from a phenotype that's more Th2 or allergic, which is usually characterized by IL-4, IL-5, IL-13 production, and they shift to a Th1 phenotype that is characterized by interferon gamma production. B cells also change, and so there's a decrease in specific IgE to that food and an increase in IgG, both 1 and 4, and that's due to isotype switching in the B cells. And then mast cells and basophils are undergo anergy, and so there's decreased reactivity of those cells at the blood and tissue level. And so these are just basic schemes of how immunotherapy might work through each of these mechanisms, but it's also important to think, well, how did oral tolerance develop to foods in each of us normally in infancy? Because these are the mechanisms that we're trying to promote through therapies that are trying to be promoting of tolerance. And so as you can see, the dendritic cell captures the antigen, presents it again in the mesenteric lymph node, and then they produce TGF-beta, IL-10, IL-27, and that leads to secretion of IgA, IgG4 by B cells, and generation of regulatory T cells. The Tregs actually express CCR9, and that helps to hone Tregs to the gut. And their presence in the gut on a continual basis afterwards with secretion of IL-10 and TGF-beta are thought to promote and reinforce ongoing tolerance. This is just a potential mechanism. No one really knows yet how oral tolerance develops in the first place, or in the cases where sustained unresponsiveness does develop, what the real mechanisms are for that, we still don't understand. This is a really busy slide that I take from this review article as well, just to show some themes and some of the OIT trials that have been done so far for Peanut, dating back to 2010. First, what you'll note is that the dose differs, and so sometimes the doses might be a goal dose of about 300 milligrams, and that's equivalent to about one peanut. One peanut's about 250 milligrams of peanut protein. Some of them go as high as 4,000 milligrams or 4 grams of peanut protein. In general, the ages that have been studied have ranged anywhere from 1-year-old up to teenagers. In terms of safety, this is where OIT has had the most problems because there is a high rate of adverse events in OIT clinical trials. And one of the categories of adverse events is GI, so symptoms such as nausea and abdominal pain, and that oftentimes can be dose limiting. And so participants in the trial might develop such persistent GI symptoms that they can't continue in the study, or they have to go down to a lower dose of the immunotherapy. With regard to sustained unresponsiveness, the first study to demonstrate that was in 2014 by Brian Vickery and colleagues at UNC, and they did this maintenance phase for 5 years. And that's a trend that's been observed over time, that the studies that seem to be more successful at inducing sustained unresponsiveness were longer in their duration of the maintenance phase. I also wanted to talk a little bit about a study that came out just in 2016, which has really changed the way we think about immunotherapy for younger children. And so this study was in 9 to 36-month-old children, and they, for 3 years, worked up to a goal dose of either 3,000 milligrams or 300 milligrams of peanut protein. While it did have a high rate of adverse events, mostly GI and upper respiratory, what was interesting is that there was a strikingly high rate of sustained unresponsiveness, and actually a higher than prior rate of effectiveness just in terms of desensitization. And so that suggests that perhaps if we target younger children with these oral immunotherapies, they might be more likely to respond favorably, both in the initial phase in terms of being able to get desensitized, but in the long term in terms of sustained unresponsiveness. I'll briefly mention a study that was done with peanut oral immunotherapy and probiotics because it garnered a lot of media attention, study out of Australia, but it had limitations in that some of the participants did not undergo a double-blind placebo-controlled food challenge at entry, and so they were excluded from the analysis in terms of the primary outcome of interest. The other thing that's important to note is that there was no control group who received oral immunotherapy alone or probiotic alone. There was only a group that received oral immunotherapy plus probiotic and a placebo group. And so while the findings seem to be encouraging, there really wasn't a comparison to see if probiotic alone would have been effective. So as we've talked about, adverse events are common in peanut OIT trials. Most commonly are chronic GI complaints, mild oropharyngeal pruritus. The risk of systemic reactions in these trials is actually increased with a few cofactors. And so if the dose is administered with exercise or a hot shower shortly thereafter, within a couple hours, if the child has a fever, if they have an upper respiratory infection, if it's a female currently menstruating, or if the dose is taken on an empty stomach, those seem to increase the risk of systemic allergic reactions to OIT. Eosinophilic esophagitis has also been found to be a rare complication of peanut OIT in less than 5% of patients. Overall, it appears to be very effective at desensitizing, 62 to 100%, and 50 to 80% sustained unresponsiveness. This is mostly, again, in that group that had a long duration at maintenance, and then the younger cohort as well. Omalizumab I mentioned before, so if OIT is combined with omalizumab, that's been done in a few studies, that actually does enhance the safety, so you get a reduction in adverse events, but it doesn't improve the efficacy. And so there are still some ongoing trials that pair omalizumab with OIT, but they don't appear to do much beyond improving safety. Sublingual immunotherapy has had much less work done, and one of the things that is notable is that the dose that can be delivered under the tongue is much lower than what can be given by mouth. And so we're talking doses in the micrograms of protein or up to 2 milligrams. And with the OIT, we were talking 300 milligrams up to 4,000 milligrams. The benefit of SLIT is that it has a much lower rate of AEs. And mostly those are local oropharyngeal symptoms. But it is not anywhere near as effective as OIT. And then finally, epicutaneous immunotherapy, where it's delivered through a patch that's changed out every 24 hours on the back or on the arm, has had only a few trials. The first one shown here was just a safety trial. And then a phase 2 efficacy trial showed that there was an increase in successfully consumed dose in both a group that was receiving 100 micrograms of peanut through the patch, as well as a group receiving 250 micrograms. Interestingly, there did not appear to be a higher efficacy with that slightly higher dose. Treatment success in general in this trial was also higher in young children. And so when they analyzed the data looking at 4 to 11-year-olds, they were really the ones that were driving this improvement in desensitization. It was 61% in those age groups versus only 14% in those over age 11. Just in the past couple of months, the top-line results of a phase 3 clinical trial of epicutaneous immunotherapy have been released and were less encouraging. And this was a trial among younger children, 4 to 11 years old. They found that those receiving the product, ViaSkin Peanut at 250 micrograms, 35% responded after 12 months of treatment as compared to 13% in placebo. The problem was that when they submitted this beforehand to the FDA, they set a confidence interval that would reach 15%, and theirs was at 12.4% on the low end. The company still plans to go ahead and submit this for FDA approval, but the results seem to be less encouraging than we expected. And so just some key points, because we've talked a lot about different methods of performing food immunotherapy, peanut immunotherapy in particular. OIT, most patients do achieve desensitization. However, only a minority develop sustained unresponsiveness. The safety and efficacy of peanut OIT appears to be better in infants and young children, and they appear to have a distinct advantage if they started early in life. Long-term adherence to OIT, however, is impacted by these chronic GI symptoms and a small risk of EOE. Compared to these other methods, OIT has better efficacy, but also is associated with more side effects than SLIT and EPIT. And the combination of OIT with omalizumab does seem to help with safety, but doesn't really help with efficacy. And in general, I think the take-home points from these is that most of the work, I think, going forward is going to focus on oral immunotherapy for peanut and other food allergens down the road. So I just wanted to spend the last part of the talk talking about what we're doing in terms of peanut allergy and other food allergy research locally here at Children's National. As Kath mentioned, we are a robust clinical site. We were one of the inaugural clinical centers of excellence for FAIR, the National Food Allergy Organization. And annually, we see over 1,000 new food allergy patients and over 2,000 returning. The one thing I wanted to point out, because I've heard that we don't have appointment availability, but we do. We have immediate appointment availability. So if you're looking to refer your patients to us, we're all throughout the region, and we can get them in this week. We can even get them in today. So please do continue to send us patients. There is not a wait to get into our clinic. We perform over 500 food challenges annually. We're one of just a handful of programs across the country to have a dedicated food allergy psychology program directed by Dr. Linda Herbert. We also have multidisciplinary clinics, such as the eosinophilic esophagitis clinic, and we formalized the collaboration with NIAID and a pediatric allergy and immunology fellowship program. We are a site for a novel clinical trial for peanut allergy immunotherapy, and pictures are shown here from some of the community events that we've done to try to raise funding for peanut allergy and other food allergy research, as well as other awareness events. I wanted to let everyone know about the particular research focuses of each of our food allergy program faculty. So Dr. Odora Lin, we're thrilled that she's with us. She in the lab is looking at B-cell responses to IL-10 and regulation of IgE and IgG4 production in peanut allergic, peanut sensitized, and non-allergic children. Dr. Amazia Coleman is looking at access to food allergy care among underserved children, and is also, along with me, part of a multi-center study looking at racial differences in food allergy morbidity and burden, along with Northwestern and Cincinnati children. Dr. Berchan Ugengil is looking at the safety and efficacy of early peanut introduction to high-risk peanut-sensitized infants. And so we have, in our clinic, children that actually have evidence of peanut sensitization beyond what the LEAP trial included. And so the LEAP trial said if they have a skin test over 4 millimeters, they wouldn't have done peanut introduction, but we have. And Berchan has some really exciting data that is in submission that will show that this is also effective in kids that are sensitized. Dr. Karen Robbins focuses her work on nutritional implications of food allergy in children, and also gastrointestinal and nutritional effects of early peanut introduction. And she and one of our nurse practitioners, Olivia Ackerman, published a very novel paper earlier last year showing that early introduction, while it might be beneficial in terms of preventing peanut allergy, might have some unintended consequences in terms of the development of a particular form of GI food allergy called EPIT. And so more work that she's doing there. Dr. Linda Herbert, who I mentioned before and is in the audience, is one of, well, actually I should say the only NIH-funded psychologist in the country that is looking specifically at the psychosocial functioning and adherence among children with food allergy. And finally, Dr. Will Sheehan, who's recently joined our group from Boston Children's, is looking at the relationship of home environmental peanut exposure to pediatric asthma morbidity. So we have a very robust and growing clinical and translational research infrastructure. This just lists our entire team because all of the work that we're doing to help kids with food allergy could not be done without everyone shown here. And if you would like to schedule an appointment, the number is listed here as well. And with that, I wanted to leave some time with questions, but thank you everyone for your attention.